right, good afternoon and evening to everyone. The Health Policy and Advocacy Committee and the Global Pediatric Surgery Committees are excited to collaborate on the Social Injustice Symposium focused on disparities in access to care. My name is Kenneth Gao from Seattle Children's.
And I'm Jay Krishnaswamy from Oregon Health and Science University. We're happy to be joined by a distinguished panel today. Representing the urban perspective is Drs. Victor Garcia and Larry Moss. Representing the rural view, Ellen Reynolds and Danielle Walsh. And finally, our global panelists, Chant Shekerdimian and Robin Petrose.
Universal health coverage is a World Health Organization goal. Coverage should include health promotion for everyone. It should exist without financial risk, and access to care should be universal. Not all countries have achieved this goal, including the United States. Access requires three critical components: physical accessibility, so that good health services are within reasonable reach for those who need it; financial affordability. This is a measure of people's abilities to pay for services without financial hardship; and acceptability, which involves people's willingness to seek the services that are available. Lack of access due to any of these three components leads to unmet health needs, delays in receiving appropriate care, an inability to get preventative services, financial burdens, and preventable hospitalizations. Access to care varies based on the social determinants of health, which refers to a person's race, ethnicity, socioeconomic status, sex, disabilities, sexual orientation, gender identity, and residential location. We will now ask our guest speakers to discuss some case scenarios to illustrate the consequences of poor access to surgical care for the children that we all are entrusted with. We'll also ask for suggestions on how to overcome these access issues. Dr. Garcia, it's a pleasure to speak with you. As we all know, each year in urban cities of the United States, there are almost 2,000 gang-related homicides that occur. So to start the discussion, allow me to present a scenario of a young teenager that is involved in a gang-related incident where he sustains a gunshot wound to the abdomen. Can you please describe what access issues this young man will encounter and potential solutions to those difficulties?
Thank you, Ken, for this opportunity. Let me begin by, suggesting that, at least in my experience here in Cincinnati, and I would suggest that throughout the United States, accessibility to care is not an issue. When a patient is shot, that child is I think, fairly expeditiously addressed by the pre-hospital care and taken to the hospital. But accessibility, as far as premier care, is not an issue. And particularly in Cincinnati, affordability is also not an issue because we have a tax levy. And so the families themselves, even though they may not be of means, will not incur an enormous amount of expense. And acceptability, we've not seen that, because when you're shot and you're thinking about dying, you're open to whoever it is that's going to accept you. To ensure, though, that you do not suffer any sort of untoward consequences as far as being stigmatized, that is yet another issue. But I would suggest that no two ghettos are alike. And what we now know is that Cincinnati is an outlier. The studies that have been done have actually demonstrated that violence in urban settings has actually gone down. And the study by Sharkey from 1991 to 2012 have shown a dramatic decrease, with three exceptions, and one of them turns out to be Cincinnati. The other two are Newark, Baltimore. What I would suggest that we want to think about is, why is it that we have such a racial stratification as far as urban shootings? One of the things that I think we need to sort of look at and consider is that violence is a social disease. And if you look at any racial ethnicity, that if they were subjected to the degree of concentrated inequality that African Americans historically have been, you will also see the same degree of violence. And you'll see that demonstrated in these two slides here. And the one in particular that I want to draw your attention to is the one to the right, where you look at Stockholm and Chicago. And even though the magnitude of violence is considerably larger in Chicago, that you'll see the same trend associated with urban disadvantage and neighborhood disadvantage. So what I would like to consider for this panel to sort of discuss, and for the audience who's listening to this, is to realize that what we now know is that socioeconomic position is the single most powerful determinant of health and development. And actually it is that really is the primary determinant of why we see the racial disparities as far as violence. And the differential exposure to something as early as childhood adversity really helps to explain not only the violence issues that we see, but also a whole host of other premature onsets of the disease, to include premature births. So when we look at the urban neighborhoods, what sociologists have very, very early demonstrated is that with hypersegregation, as far as African Americans and other ethnicities, significant percentage of children are living in punishing and toxic neighborhood environments that actually predict not only how that generation of children are going to be affected as far as violence is concerned and subjected to gang violence, but also a host of other health disparities. And this then becomes intergenerational. And the environment has been so characterized as a brave new world, suggesting that there are a host of biological consequences as a result of individuals living in these concentrated environments. What we also have to consider when we look at violence in urban neighborhoods really is what role does the environment play? Now, we know that environments that are racially segregated and impoverished are really subjected to increases in pollution, and then there's asthma associated with that. But I think most people don't realize that Flint, Michigan is not an outlier, and that lead poisoning, which has been inextricably linked to antisocial behavior, is really very, very much a racial ecological phenomena. And in Cincinnati, as well as in Chicago, we have some of the longest longitudinal studies, not only documenting that longitudinally, but also associating it as far as criminal behavior. So we have then, as a result of the punishing and toxic environment, not only the concentrated disadvantage, but the toxic as far as lead contributing to it. In Cincinnati, what we now appreciate is that if you are born in one of these most impoverished neighborhoods that are subjected to these increases in violence, if you don't move out before you're 10 years of age, you're going to be there for the rest of your life, speaking to the generational inheritance then of phenomena that we see early on. This phenomena that has been described then by sociologists has also been described by economists. And Raj Chetty, in his work that is built on the moving to opportunity work, has demonstrated some rather sobering consequences. And that is that when you look at what percentage of Black children live in environments that promote upward social mobility, it is only 5% of African American children. And if you then extrapolate, that means that those 5% are really going to that 95% of children are going to be subjected to this cycle of violence in the inner city neighborhood. But again, not just cycle of violence, but also premature diseases. So what this calls for, as we look at not just going beyond affordability, accessibility, and acceptability, is really how do we change that environment where children are then exposed to these terrible degrees of violence? And that calls for really something that the sociologist, urban sociologist Rob Sampson has called a durable urban policy, something akin to affirmative action for neighborhoods. It's looking at neighborhoods and not just looking at individuals, and doing it with the realization as it's become rather quite evident today with this death of George Floyd, that we have to look at racial policies, racial tendencies to really make sure that what we implement is scalable, but also meets the unique needs of people like me who live in these environments. So you might ask then, as healthcare providers, is this in our lane? Or as Kevin Volk from the University of Pennsylvania has asked a question in the New England Journal of Medicine article, is this our business? What business are we in? And I would suggest that this is our business. It's not about just healthcare. It's really about what do we need to do as healthcare providers to ensure the population health, the well-being of the health of the children that we are responsible for. And I would also suggest, as Kevin Volp suggests, that in the future, successful hospital ventures are going to be those that really expand their horizons and look at then what needs to happen. What do we need to do differently in order to deliver not just the quintessential excellent healthcare, but also what we can do to ensure that the population that we serve enjoys health, beginning with the children. Otherwise, we too may be facing a Kodak moment.
Dr. Walsh, thank you for joining our panel to discuss barriers to access. According to the National Children's Center for Rural and Agricultural Health and Safety, tractors cause over 40% of accidental farm death in children under 15. So allow me to present a teenager who was riding on a tractor, fell, and injured her leg. Can you provide us with some of your thoughts in terms of what this young patient will encounter in terms of barriers to access to care and how we can help that?
Thank you, Ken. It's a pleasure to be here today. I do work in a rural setting in a 29-county catchment area that goes all the way to the coast of eastern North Carolina. And in the bottom right image of this slide, you'll see that dark green area is this large swath of land that we serve. And most of the other hospitals in there are really just critical access hospitals. So the first problem we encounter with pediatric rural trauma is actually getting the patient into our care. And it starts at the scene of the accident. So out on these farms, many of them don't have cell reception. So from the time the person is injured by the tractor, someone has to find them, go back in an area to get cell phone reception, actually make contact with 911, and then we have to try and get an ambulance to them or a helicopter to them. So many of our delays come at a very early stage. It might be 2 hours, and we've lost that critical hour to even get them picked up. When they are picked up, they're almost exclusively going to go to one of these critical access sites where there's a very limited pediatric experience at all and an even lower experience of pediatric trauma. They aren't used to having to stock the resources and utilize those resources on a regular basis. They're lucky if they see 2 pediatric traumas a year. And so their comfort level, both at the physician and nurse and caregiver level, are all very low. Their pharmacists don't know how to dose these things off the top of their head. And so you set up this condition for pediatric trauma where it's low volume and it becomes increasingly high risk for you. Fortunately, once they get into those critical access hospitals, we can improve the system of care of getting them to our pediatric centers. So we can send pediatric trucks staffed by pediatric caregivers. We can also fly them to there. One of the problems that you'll run into is even if the critical access hospital has their own EMS truck, they don't have people who are comfortable transporting kids. So I'm fortunate that we are able to mitigate that by positioning resources out in the communities. But sometimes weather makes it even worse. The distance might be longer than the helicopter can fly or the truck can drive. So we have to negotiate and plan in advance for refueling. So physical access to us is very difficult. In addition to that, there's the component of affordability. So in North Carolina, we were a non-Medicaid expansion state. Nonetheless, about 60%, more than half of our patients are Medicaid. Only a small percentage of them are private payer, and equally large is the population that are self-pay. Farmers and people in rural communities rarely have that savings, that cash backing to afford a major accident. There's a cost of transporting them. You might be talking about 2 or 3 different ambulance rides, plus a helicopter ride that might include a refueling stop. So even the cost of getting patients to us can really compound the economic hurt to the family. Once they get to us, many of them struggle with caring for kids at home, caring for their farm animals, and caring for the child in the hospital at the same time. Transportation over several hours of driving each day, even for a single visit, can be beyond the cost that many of these families can bear. And so it's important to have social services structures that have gas cards. You know, we are blessed to have a Ronald McDonald House where we can at least house them some of the time. But it can still be a challenge for parents to manage their responsibilities in their home with a child in the hospital. When they leave us, we have issues with follow-up care. So in some of these counties, the only resource for follow-up physician care are county health departments. So you might have 1 or 2 nurse practitioners and 1 or 2 medical assistants are the only resources locally that these patients can count on to do wound checks and remove sutures and manage them when it's really difficult for them to get back to our children's center. So our post-discharge setup also has affordabilities. I don't have access to home health care in every county that my kids come from. I may not be able to get a child-sized wheelchair for an additional period of time, or we have to figure out how to get that wheelchair to them. We don't have outpatient physical therapy, occupational therapy, speech therapy, wound dressing supplies sitting in these counties. So it becomes critical that we plan for that before they leave our hospital. Sometimes it's even more complicated. Their home might not have running water. So when we say clean your wound for, do wet to dry dressings, we got to make sure they actually have water to do that with. Do they have refrigerators for medications that might need to be refrigerated? Do they have access to healthy foods? Because in some of these counties, the only grocery store available is their backyard, whatever's growing, or the gas station, because the gas station is often the grocery store as well. So do we have access to the nutrition that they need to heal? And can they afford to buy it? And then there's the issue of acceptability. So we are very fortunate to be in institutions that have this as our mission. I cannot tell you how critical it is for your hospital and your university to really be passionate about trying to improve the stature of the rural patient and especially the rural trauma patient. And in return, because of all of the outreach that's done, we are fortunate that patients are quite gracious with it. It means a lot to me when they come in with ears of corn from their farm, because I know it's special to them, and I appreciate that showing of this is the best I can give to you. It's a message of love. There's great community, though, within these rural communities. That's one of the strengths, and that's one of the reasons people stay there. Your patient's family might not have a car, but there's a really good chance that someone else in their community is willing to loan them that car to get them to be with their children, because they know that they have to take care of each other. And that spirit of we're all in this together is what brings these rural communities out in support of each other when someone is hurt. And then the role of acceptability also falls on us as pediatric surgeons. We have to ask about those social determinants of health and how they're going to take care of each other when they leave there. And how you ask it is key. So you can't just say, do you have a refrigerator? Do you have this? It's, how can I help you make sure that you and your family are well taken care of? And do it from a perspective of caring and interest in them as a person and a family and a community that really bonds them to you in a way that is really special and something I really find rewarding in my job. And then finally, we try and figure out how to work with remote care. I've mentioned that they don't always have cell phone reception to just do follow-ups. It may be that they have to go to the local library truck, or someone has a Wi-Fi at a different store that's in their community, that they have to go there in order to interface with us. But they do that, and we accommodate them because it's the only way to connect with that community. In conversations with the family, that I'm happy to do it another way, but if this is the best you have, I'm going to take you where you are, and we're going to take care of your child. It's important that you build relationships with those local caregivers so that they know who you are when you call them, and they trust you, and they understand that you value the information you're giving them about the patients that were previously in your care. And it's about anticipating what needs and complications might arise and having plans in place that the family can intervene as early as possible, so you're not coming back with septic, infected, more complicated wounds than you might have had if you had been thinking thoughtfully before you discharge them. So we come to solutions. In our area, one of them is improving access. We've positioned 5 helicopters and 24 ambulance trucks throughout these communities so that we can move people stage by stage to us when necessary. We create systems of communication that make it easy. When that critical access hospital calls, our call center in the hospital only is going to connect them to one person and one person alone who's going to accept any and all trauma, and we're going to make the transportation arrangements for them. It's about doing outreach to them. It's about teaching farming communities at their community centers, at their churches, how to do stop the bleed and how to control bleeding and slow it enough that the patient can get picked up and get to that critical access hospital and then get to us later on. It's about reviewing pediatric intubations and placing IVs and what fluids to use. And we are fortunate to have a simulation truck in the form of a tractor trailer that's shown here in the photograph that we're able to take out to these rural centers and community centers in order to train caregivers who only see those 2 or 3 traumatized kids a year how to be more comfortable and to put a face with the names so they know when they talk to me that I'm going to listen to them and that I'm going to communicate back how they did and what we can all do better for that child. And they love hearing the success stories that they did good. And that's important. It's important also that we're advocates for our patients. So at a state and national level, working for insurance coverage, working to fund those community hospitals and those critical access centers, and working through trauma collaboratives to develop those best practices that these rural settings need to be able to open up and implement on those few children per year. Thank you.
Sean, thanks for joining us on this great panel. As you know, in low and middle income countries of the world, children use roads as pedestrians, cyclists, motorcyclists, and vehicle passengers. Some children work, play, or live on the road, and this exposure makes them particularly vulnerable in traffic. The result is millions of fatal or disabling injuries each year. In most countries, road traffic injuries are one of the top 2 causes of death, with the highest rate amongst 15 and 19 years of age. So allow me to present a teenager walking on the roadside and proceeds to get hit by a car. Can you give us some of your thoughts on the treatment of this young patient and the difficulties as far as access to care?
Ken, thank you for the opportunity to speak on this, and thank you also for choosing the example that you have. As injury is, as you mentioned, the leading cause of death of children over 1 year of age. And there's a huge disparity between low to middle income countries and more developed nations, with 95% of all childhood injury deaths occurring in low to middle income countries, with a death rate that is double that of high income countries. And in fact, the disparity doesn't stop with just mortality. 50% of children in low to middle income countries leave the hospital after an injury with some disability. And that tallies the disability adjusted life years to that of triple those in high-income countries. All of this leading to an annual economic cost of just road traffic injuries alone of up to $65 billion US. When we look at physical accessibility issues, it's no surprise that a large population of children throughout the world live in areas that have limited or no access to pre-hospital and hospital trauma care, as is depicted in this map of a region in Uganda, with areas outside of the blue and green shade being areas where patients would have limited access to pre-hospital and hospital care, or access that's more than 2 hours away from the nearest hospital. But it's also important to note that it's not only about the presence of an ambulance or pre-hospital care or a district hospital, but what those services are providing. The study on the right demonstrated disparities between high-income and low and middle-income countries within pre-hospital care. And as you can see, there is some disparities between the presence of some supplies, such as endotracheal tubes and tourniquets. But what I'd like to point everyone's attention to is processes that are circled in the red. As an example here, the major trauma notification protocol and chest injury management guidelines show major disparities with presence in high-income countries and often or never available in low and middle-income countries. And as we all know, these are the processes that help dramatically improve outcomes in trauma care in children throughout the world. With regards to financial affordability, again, no surprise that there's major disparities in terms of financing of healthcare systems. The world map on the left shows public health expenditure as a percentage of GDP in different nations, with the World Health Organization recommending that at least 3% of a country's GDP being invested in healthcare. We can see that most of the countries in Latin America, Africa, Southeast Asia, and the former Soviet space not achieving that goal and spending less than 2 or 3% of their country's GDP on healthcare expenditure. And with underfinancing like this, it's no surprise that studies like the one where the graph on the right comes from demonstrate the significance of economic consequences of injury in different parts of the world. This particular study from Cameroon was a household survey that surveyed injured patients, and the results were striking. The mean treatment cost of an injured patient was equivalent to 16% of their annual salary, with 48.5% having to spend savings, borrow money, or sell assets to pay for this treatment, and over a third experiencing severe financial hardship, such as a new inability to afford necessities like food and or housing. In Armenia, where I do most of my global health work, acceptability is probably the biggest challenge. A small country with a surplus of physicians, a surplus of hospitals and infrastructure due to its Soviet past, yet many people still are unwilling to seek care or have a major distrust of the care that they receive because of a perception that that care is of low quality and actually dangerous for them. But this perception is not unfounded and is very well overviewed by the study that was published in the Lancet in 2018 that looked at preventable deaths in low to middle income countries. It identified 8.6 million excess deaths that were amenable to healthcare. Way less than half, 3.6 million, were due to non-utilization or non-access to that healthcare, while more than half, 5 million, were estimated to be due to the receival of poor quality healthcare. And this panned out in the trauma components of the study as well, with more than half, 372,000 deaths occurring because of patients receiving poor quality healthcare rather than not having access or not utilizing that healthcare. So with regards to solutions, certainly improving access to trauma services via infrastructure and human resources is one solution, but one that's expensive and difficult for us to do, being outside of government. With regards to increasing financing, certainly advocacy and or further research that demonstrates the need and the value of further financing is something that we can be involved with and that is very necessary throughout the world. But I would argue that the low-hanging fruit for us to be involved as non-state stakeholders in assuring that basic levels of quality and safety are achieved in trauma care throughout the world is where we can get maximum benefit for our inputs. Thank you very much.